The other important aspect is um, assess and understand the intellectual level and the neuropsychological profile of the individual with TSC that is manifesting some dysregulated behavior. Because in some cases, we can provide accommodation or resources like hand sign, picture cards, devices, for example, if the problem is a communication barrier. One extremely important thing is to always think of a medical workup or for sudden and unexpected changes. So whenever the behavior changes, and it's not like the baseline behavior, there's a worsening of behavior, and we cannot identify clearly a cause, we should always think about medical reason behind that. It could be new seizures, it could be symptoms of a subependymal giant cell astrocytoma, it could be physical illness, it could be adverse events of medication. All of those and more should be considered and ruled out. There are sometimes alarming behavior like lethargy, confusion, vomiting, or physical pain, and those need urgent assessment. Once we have ruled out the medical causes, underlying causes, then the non-pharmacological strategies should be the first line treatment. And medication may help and should be used for dysregulated behavior, but after careful systematic evaluation and always together with non-pharmacological intervention. And then the next cluster is the eat and sleep cluster. We are talking about things like eating too much or eating too little or eating unusual things. We call it pica, eating things that are not edible. And sleep disorders like problems with falling asleep or problem with maintaining sleep through the night. The recommendation about this specific cluster were that eating difficulties do occur in TSC and may be associated with a range of TAND manifestation or physical health manifestation. So sometimes, for example, picky eating could be something that we see also in developing children, but for example, in autism, we sometimes have a very restricted and selective diet. Or in anxiety, we may have overeating or undereating. Or again, sometimes we may see problem with eating due to mouth ulcers because of medication side effect. So whenever assessing eating problem, we need to think about all those aspects. And having a comprehensive workup and an interventional plan in the context of TAND and physical health related association. There is no scientific evidence to recommend over-the-counter supplements or restricted diet for TAND. The ketogenic diet is used for refractory seizures, but not as a dietary intervention for TAND specifically. When it comes to sleep, we know that sleep difficulties are common in general, but in the TSC population are even more common. And this is across age, sex, and genotype. And those sleep difficulties should be monitored on a regular basis. With sleep, sometimes we should always try to understand if this is a cause or a consequences. For example, sleep difficulties may cause problem in school, leading to dysregulated behavior or impulsive behavior, or poor scholastic performance, or even seizure. We know that lack of sleep can be a trigger for seizures. But on the other side, sleep can be a consequence of TAND and neurological manifestation. For example, in autism, we often see lots of problem with sleep routine. In anxiety and mood disorders, we can see insomnia, or we can have awakening during the night due to nocturnal seizures or side effect of medication. So there's kind of a bidirectional association, and we need to figure out what is the cause and what is the consequences possibly before thinking about treatment. And so investigating physical causes, psychiatric causes, and treating those should be the first step. Treating seizure, treating pain, treating anxiety, if those are the cause for a sleep problem. And non-pharmacological strategies should always use before pharmacological strategies. So modification of the environment, bedtime routines, limiting access to technology, as much as we can do modifying all those things, this should be done before thinking about medication for sleep. And then the mood and anxiety cluster. This is referring to anxiety, depressed mood, extreme shyness, mood swing. And again, this is cluster that should be monitored in all children and adults to ensure early detection and treatment. We know that up to 56%, especially adolescents, especially adults, may have mood and anxiety symptoms. And those are highly underdiagnosed and undertreated, especially in those individuals with cognitive difficulties. In fact, in an individual with intellectual disability, it's often difficult to recognize symptoms of anxiety or depression. Sometimes they appear in a different way as a change in a change of the behavior, a withdrawal from activities or reduced enjoyment of previously motivating activities. So things that do not look like anxiety or depression in general, but should be investigated. And mood and anxiety may also present as manifestation of physical health disorders. We know the role of seizure or other health condition that can contribute to anxiety and depressive symptoms. So even for mood and anxiety, we don't have specific evidence for the TSC population, but we have good evidence-based treatment for the general population that include non-pharmacological and pharmacological intervention. And so we can apply those evidence that is available to our population. Another recommendation was to consider the co-occurring biological, psychological, and social aspects. So the approach to treat mood and anxiety should be very individualized. And then the next cluster is the neuropsychological cluster. We are talking about things like memory, remembering things that have happened, attention, like concentrating, not getting distracted, dual tasking, or visual spatial task like solving puzzles or building blocks. Executive skills are things like planning, organizing, flexible thinking. And the recommendation for this cluster were that all the individuals with TSC should receive an assessment regardless of their intellectual abilities. In fact, even those individuals with TSC that have good cognitive skills or high cognitive skills, they have a high risk of have neuropsychological deficits. And as I was saying before, the majority of the individuals with TSC tend to have an uneven profile. So some area of strengths and some areas of weaknesses that could be associated with a lot of difficulties in daily functioning in school and at work. So the second recommendation was for ongoing screening and monitoring. And then the fact that some neuropsychological deficit may have a major impact on functional abilities and may present in different ways, in various ways. So they may present with anxiety and feeling overwhelmed. They may present with feeling dysregulated, having difficulties in education or struggling at work. One other recommendation was that those individuals with a specific diagnosis like ADHD, autism, learning should receive a formal neuropsychological evaluation because they are even a higher risk of neuropsychological deficit. And for those type of difficulties, there are non-pharmacological coaching and training strategies to strengthen those neuropsychological deficits. And of course, accommodation, specific support that can be put in place in school, but also in the workplace. The next cluster is the overactive and impulsive one. So thinking at things like overactivity, restlessness, impulsivity. And as you may know, overactive and impulsive behavior are extremely common in TSC and should be evaluated not only in children, but also in adults. And all the individuals with some overactive and impulsive behaviors should be considered for a formal diagnostic assessment of ADHD. So ADHD is definitely the most common psychiatric disorder associated with overactive behavior, but it's not the only one. So again, when assessing a kid with overactive behavior, we should think about physical health, because sometimes a manifestation of physical illness or adverse effects of medication, we should think about their developmental level. So if there is their overactive behavior in keeping with the developmental level or not. And we need to think about environmental thing, an overstimulating environment or other mental health concern other than ADHD. So ADHD, again, we have recommendation for the general population with the ADHD that we should apply to our population of TSC individuals with ADHD. And the guidelines recommend that for moderate to severe ADHD, psychostimulant could be considered and could be trialed, like methylphenidate or other psychostimulant. And even when ADHD is accompanied with epilepsy, with intellectual disability, or with autism, there should be a response to psychostimulant, and so those should be considered. And finally, the scholastic cluster, so reading, writing, spelling, mathematics. And again, the recommendation was to monitor and screen early, because up to 60% of individuals with TSC may have difficulties in learning in those academic skills. And those difficulties may persist in adulthood. One point to remember is that sometimes delays in language development or other milestone early in life could be a marker for later development or of scholastic difficulties. And so this should be taken in consideration. When we have a kid with learning disability, we need to consider an individual educational plan to support their learning. And possibly the school-age children with TSC should be supported in the most appropriate educational environment. So for some of them would be a full inclusive mainstream classroom. For others will be a special classroom. All the educational environment and the educators in particular should use high quality teaching strategies, sometimes individualized teaching, sometimes appropriate accommodation, but again, highly personalized based on their needs. It's important that the educators are aware of the overall TAND profile of a child with TSC, and to consider not only the learning difficulties, but all the comorbid condition. And finally, planning for transition, again, is very important. So these were the 7 cluster, but there is the psychosocial cluster that is kind of a wraparound. And this is not a cluster just for individuals with TSC, but it's also for their caregivers, because things like low self-esteem, very high level of stress can impact family relation with community, and can have multiple level of impact in the family life. And monitor the psychosocial health and well-being of all the individuals of TSC was the first recommendation. But the second was to monitor the psychosocial functioning of all family members who live with TSC. So not only the individual with TSC, but all the people that care for him and are living close to him or her. The recommendation was to provide integrated and well-coordinated care to families, possibly through TSC clinic or through a clinical care coordinator that is able to maintain an overview on the trajectory and need of the specific individual.
Sorry to interrupt. Would I be able to ask a quick question?
Yes.
It's just easier than typing it for this specific question. And it's related to what you're talking about right now. And you might go into it, so you can delay it if you want. But I was just looking at those like 6 or 7 different categories there. And some of them are more obvious, like the scholastic would be like the school would lead that, and autism like behaviors like an ASD diagnosis, and then behavioral interventions for that. But like for dysregulated behaviors and for like overactive or impulsive, like who's leading that? Like I know it's being diagnosed or looked at like at the TSC clinic level, but then if a family's really struggling with that, is that like a behavioral therapist, or like who is the person in the community, or like who leads that, or who like stays connected with the family to like offer strategies or like look at it like much more closely? Because some of them are so clear to me. We have a school, our son is 7, so some are really clear to me like who the person is, but for those two, like dysregulated behaviors and overactive and compulsive, like we struggle with that a lot, and I'm always a little bit like, who do I go to?
Yes, and that's a good question. So ideally, there should be a team of healthcare providers that are taking care of that. Potentially, there should be a developmental pediatrician, but a behavior therapist. And when I think about a behavior therapist, I think about someone that can provide support in school, but also maybe someone else that can provide support at home. Because you are correct, there are different type of behaviors, maybe in different environment, different triggers. And the ideal thing would be to have all these people connected and having the same plan and the same type of approach, so that when there are changes that needs to be made at home to treat or to try to address some specific behavior, the same type of approach is taken in school. And if medication are needed, all the people involved in the care of the specific child are talking to each other and deciding together and moving toward the same direction. So generally, for dysregulated behavior, for overactive behavior, again, first understanding the situation, understanding if there is a specific diagnosis, is a dysregulated behavior because of ADHD, or of an ADHD diagnosis, is a dysregulated behavior because of ASD diagnosis, or both. There's a intellectual comorbidity or not. So all those are questions that needs to be answered before thinking, okay, let's do this. Let's move toward this plan. And definitely the behavioral therapist is the one that should observe the kid in the different environment and have the better sense of what is it, the trigger, what are the things that can be done. Because as a physician, it's hard for me to gather all the information in a brief appointment or even in an hour appointment. It's hard because I don't have the kid in front of me all day long, and I don't see the trigger. I don't see what's happening in school. So communication is key. Having a plan and that is shared is extremely important. I don't know if I
You did.
answered your
No, that really was
question.
helpful. I guess the only thing that I would follow up is just, I guess it's that actual behavioral therapist that I'm not sure like who that is. And like, is that out of pocket somebody we pay for? Is that something that is typically available within like like a hospital setting would connect you? I guess that's maybe the one piece where I'm not quite totally clear. And I mean, I can even
Yeah,
follow up. Maybe it's starting with
yeah,
like our pediatrician or the TS clinic and asking then like in terms of what the next steps for a behavioral therapist would be.
yeah. I will recommend that because depending on the area where you live, the
Yes,
type
it
of
might change.
services yes, yes.
Okay,
And in
that's
general,
helpful.
yeah, in general in school, you will have some type of support, but then depending on where you live, there could be some specific
Thank
for that
you.
area. No
Thank you
problem.
so much.
Okay. Going back to the psychosocial support, um, I was saying the recommendation were to have an integrated and well-coordinated care for families who live with TSC, and we were mentioning the possibly through a TSC clinic, but the TSC clinic is not always available in the area where you live, so it could be a clinical coordinator. The other recommendation was about the psychosocial intervention and practical support, especially when family are facing a high level of stress. Psychological support or respite, for example, should be provided. Um, and the focus was on quality of life, on measure measuring quality of life and improving quality of life rather than focusing only on reducing the symptoms or fixing a specific problem, but improving quality of life for the individual with TSC and for their families. And the other recommendation that was made was about optimizing the employment and professional life. This both for the individuals and for the caregiver. So thinking about adults with TSC, having access to career counseling or assistance seeking work or coaching at work. For caregivers, this may include discussion about uh, reducing working hours or workload or alternative financial support. But the final and very important point was that we should put a lot of more attention on care for the caregivers, given the impact of TAND and the fundamental role of caregiver. Supporting caregiver is essential. And then we have looked at the various recommendations for each one of the cluster, but the TAND consortium expert panel made 10 core principles that are somehow that are going behind the specific cluster. And this course, I want to look at this core principle briefly with you because the first was to screen everyone for TAND because everyone is at risk for TAND. We know again, 90% of the individuals with TSC have some of the TAND manifestation. And the screening should be lifelong. The monitoring should be a lifelong monitoring so that we can capture the emergence of TAND symptoms. The screening with the checklist should be done at least annually to allow for early identification and early intervention. Another important thing is that TAND clusters cluster together. It's very atypical to find only one cluster. One difficulties related to one specific cluster. Most of the time, we can see a few clusters involved, a few type of different concerns. And the other aspect was that always consider the impact of physical health problem and medication on TAND. Work with families and caregivers and lived expert in TSC. Generate biopsychosocial approach. And so whenever thinking at intervention, we have to consider the biological, the psychological, and the social aspect as a whole system. Apply evidence-based. So we have evidence-based for many of those conditions that we can apply to individuals with TANDs. And finally, the recommendation to strive for optimal functional outcomes and quality of life. And the cluster that we have reviewed so far are part of a bigger project. And in fact, in 2019, the Tandem project was launched as an international interdisciplinary project with 3 main aims. The first aim was to develop a self-report and quantified version of the TAND checklist, is the one you see here, and to build this checklist into a mobile application. And so the checklist has been published and you can find it online if you follow this link. And the next step will be to have this checklist in the application itself. The second aim of this project, was to create recommendation for identification and treatment of TAND. And the recommendation are the ones that I showed you before, the recommendation for the different clusters. And then the next step is to embed those recommendations and TAND toolkit into the application so that individuals with TANDs and their caregivers could access the application, complete the questionnaire, and have recommendation, guideline, and toolkit to know what to do next, who to refer to, or who to talk to for help and next steps. And the last aim was to establish global TAND network through research capacity building and impact activities. So if I have to summarize all the discussion today in 3 words, those will be screen, act, and repeat. And again, the importance of screening for TAND manifestation so that we can identify early any concern in the moment this new concern emerge, and then act, do something, and do something may be refer for a further assessment or refer to another specialist or start an intervention. And again, whenever we think of intervention, we want to think of the 3 aspects, the biological, the psychological, and the social aspect. And then again, repeat the screening to identify and treat. And this is our few references if you're interested. And thank you for listening to this long discussion, but I'm happy to take any questions.